Thank you all for joining us this evening. My name is Cindy Pankella, and I am the Senior Director of Physician Services here at the American Osteopathic Association. Our webinar this evening is called Medicare Physician Payment Innovation in the Age of COVID. Before we get started and our speakers are introduced, I wanted to go over just a few housekeeping things with you all. So currently all the attendees are muted. You will remain muted throughout the program. Should you have a question, please type it into the Q&A box found on your screen, and then the speakers will address these questions after the presentation. For help with technical difficulties and non-speaker questions, use the chat box, and I will respond to you as soon as I can and hopefully be able to help with whatever technical difficulties you may be having. We are recording this presentation and the slides will be available as well. Those should be posted tomorrow or Friday at the latest. And to obtain CME credit, once the presentation is completed, you will be able to go back to the AOA Online Learning at osteopathic.org website and go into the program, and within there you will see the post-evaluation. I'll talk a little bit about that again at the end of the webinar to remind you. And then a little bit of a disclaimer just to let you know that this presentation is not to be construed as legal advice. This strictly is for educational purposes. The content that the speakers will provide was current when they created the slides. And again, it is strictly for educational purposes. So, and I will now move the slides on a little bit and do a little bit of introduction on our speakers. We're very thrilled to have two speakers with today, Sheila Madhani and Mara McDermott, who are from the McDermott Plus Consulting Company, and they'll tell you a little bit about themselves as we begin our presentation. Sheila, I believe, is going to start us out. Sheila?
Thank you so much, Cynthia, and thank you for the introduction. We're really happy to be here and appreciate the invitation to speak. As this first slide indicates, the focus of our remarks today in this discussion is really the impact of COVID, specifically on Medicare physician payment and innovation. So my name is Sheila Madhani, and as Cynthia indicated, we're with McDermott Plus. I've been with McDermott since about 2015, and I work primarily on physician quality and payment issues. I've worked with physician medical societies and industry on issues ranging from code development to the physician fee schedule and physician quality reporting. To this audience, I'd like to mention that I do come from the Physician Association world. Prior to joining M+, I was staff at the American Society for Radiation Oncology. I've also worked with the American College of OBGYN and one of the main GI societies. I'm joined here by my colleague, Mara McDermott, who I will let introduce herself when we get to her section of this presentation. But just to suffice it to say, as a bit of a teaser, Mara is really steeped in the world of Medicare payment models and delivery systems. And I'm sure she'll be able to provide some really critical perspectives on the impact of COVID on the models and really the value movement in general. So just a quick slide on us. We're a DC-based firm. We work exclusively in the healthcare space. And as I mentioned, we work with a range of healthcare clients, hospitals, physician groups, industry, and we have this great team of folks. We have some docs that work with us. We have lawyers, we have data analysts, we have folks who used to work on the Hill and at agencies. And so I think that combination allows us to provide some really effective and practical and hopefully this will come out in our presentation today and that you will find useful at your practice. So with this presentation, I think we have three goals in mind. CMS and HHS, they've implemented a number of flexibilities in response to COVID. And today we really want to focus on the flexibilities that relate to the Medicare Quality Payment Program, both those that relate to MIPS as well as the Advanced Alternative Payment Models track. And so we want to talk about what they did today, but we also want to think about what does the pandemic and the flexibilities and sort of the changes in sort of the environment mean for payment innovation today in the short term, and sort of also in kind of a more long term, the impact to all of this. So in making their changes and these waivers and flexibilities in the payment innovation space, what the agency said was that they appreciated that for clinicians to participate in quality programs, be it MIPS reporting or innovation models, there are burdens on clinicians where you have to report quality measures. And then they also appreciate that because of the change of what was that the pandemic caused in terms of utilization rates and resources you may need to have implemented in order to maintain safe distance and keep things safe and healthy for both patients as well as your staff. The costs may have been skewed and things just were not the same as they typically are. And they appreciated that these disruptions required some modifications to these payment programs. So they announced flexibilities related to payment innovation. There were really two vehicles. At the end of March, there was an interim final rule released. And in that rule, there were the flexibilities related to MIPS, as well as a number of Medicare payment models that are listed on this slide. Then earlier this month, in June, CMS announced modifications to numerous other innovation models. Most of these changes or flexibilities really fell into three buckets. There were changes to sort of financial methodology changes, how costs were measured, and if you were seen as being above or below some sort of financial where you'd get dinged. There were changes to quality reporting, and then appreciating sort of all of the impact of these things of the pandemic. There were changes to model timelines where things may be pushed further back. So I'm going to focus my comments here in the next few slides on the impact of MIPS, COVID on MIPS. So to start with, in terms of performance year 2019, as you may recall, for 2019, you had to have your quality measures and data, all your data reported by the end of March. So initially, CMS had extended the deadline for submitting quality data, but then I think they realized that more needed to be done. And so they extended the deadline and implemented their extreme and uncontrollable circumstances policy. And this is an existing policy in MIPS, and other models also have this policy. And the idea of this policy is that if you're a clinician located in a region that's been impacted by some extraordinary circumstances, usually it's sort of a hurricane or something like that, the way that the policy works in MIPS is that you will be protected from negative adjustments. They will say for this performance period, you will get a neutral adjustment. So for COVID, the agency said the entire country has been impacted by this pandemic, so the entire country will be considered part of a disaster area. So for what they said for individual MIPS clinicians, so if you're participating in MIPS as an individual, you would automatically receive a neutral payment adjustment for your 2019 performance year that impacts 2021 payment adjustments. So if by April 30th you submitted data for one or fewer of the 4 performance categories for MIPS, CMS said you will get a neutral payment adjustment in 2021. If you were a clinician that submitted data for 2 or more performance categories, perhaps before all of this happened, your data would be analyzed, and you will receive a positive, negative, or neutral payment adjustment. In terms of the group, if you're participating in MIPS as a group, the policy applies, but it is not automatic. CMS required groups to submit an application by April 30th. The difference here is if you were a group and you submitted an application, that application would void previously submitted data. So really, what does this mean both for the individual clinician or individual group, but as well as for overall for MIPS clinicians in 2021? So the issue becomes MIPS payment adjustments are required by law to be budget neutral, which means that any positive adjustments have to be balanced by negative adjustments. And so if in 2021 CMS is protecting physicians and saying that there are going to be, you will not receive negative adjustments, as a result, there will be fewer negative adjustments to fund the positive adjustments. And so we would anticipate that the positive adjustments for 2021 will be lower than expected. And you may, MIPS has now been around for a couple of years, and so you may recall, or you may be thinking about your 2020 or your 2019 payment adjustment, which was lower than expected. So, for example, in 2019, by statute, the range of MIPS adjustments were supposed to be plus or minus 5%. But in reality, the adjustments range from negative 5% to a positive 1.68%. So even a clinician that got a perfect score on MIPS really only got a 1.68% adjustment because there just weren't enough dollars to get up to that 0.5%. And so we would anticipate that because of this policy, that may even be lower than that 1.68. So, one other thing I did want to mention, since we are talking about performance scores, and it's not on the slide, but I did want to flag for you that right now you are in a period when you can review your MIPS performance data before it goes public. CMS is going to be posting your 2018 MIPS performance data on Physician Compare, which is the website that Medicare beneficiaries use when they're selecting a Medicare physician. So right now, between June 22nd and August 20th, there's a 60-day preview period. So if you go to the website, you're able to look at your data, make sure it's correct, or there aren't any errors or things like that. So I did want to mention that to everyone. So here on this slide, we did want to mention some other MIPS flexibilities that CMS is implementing. For performance year 2020, which is right now, CMS created a new improvement activity, which is one of the 4 performance categories. And for those of you who are participating in a COVID-19 clinical trial, you can get credit for an improvement activity under MIPS. CMS is trying to encourage participation in clinical trials. These could be, your participation could be in an NIH type trial, or if you're reporting data through some sort of data repository or registry, that would also apply. CMS also has finalized that for performance year 2021, they had previously finalized that there were going to be greater requirements on measure testing and data collection for quality clinical data registries beginning in 2021. CMS has delayed that policy by 1 year and said that would be effective in 2022. So I wanted to spend a couple of minutes thinking about, okay, they have implemented, protection for your 2021 payment, but are further flexibilities and protection, is it needed? And while I think it's helpful that they've protected clinicians from negative adjustments for 2021, the pandemic is still going on. Practices are still experiencing challenges on a number of fronts. And I think that, CMS may need to apply additional flexibilities. The agency has indicated that for performance year 2020, they are continuing to monitor the program and will look at the need for additional flexibilities. And so I think in thinking about what is needed in the future, I think there's two timelines to think about. So there is the performance year 2020, which CMS has said that they are monitoring. And I think things that the agency needs to think about is if utilization and costs for 2020 may be very different than what would be expected, and your capacity to report quality measures may be different. And so I think those are things that need to be taken into consideration as the requirements for 2020 are considered. The other timeline to think about is 2021. And what you do in 2021 impacts your payments in 2023. So the proposed rule for 2021, the Medicare Physician Fee Schedule proposed rule that sets out the rules, is coming out in July. But last year, they already finalized some policies for 2021 MIPS. And one of these policies was the gradual implementation of what's known as the MIPS Values Pathways Framework. And that was supposed to begin for some physicians in 2021. And really this MVP is called, it's sort of like a mini APM where clinicians would report on a small group of measures centered around a condition or a procedure. So I think that something to look out for in the rule is, will CMS continue with this idea of the MVP framework in 2021? Will practices be in a position where they can kind of take on sort of a new way of participating in MIPS when they are still sort of contending with keeping their practices afloat, in the midst of this pandemic? And, one of the things to think about is, the proposed rule comes out in 2021 or in July. The final rule comes out in November. And so they may kind of wait to make a final decision until the final rule comes out in November to get a sense of what, where things are at that point. So I think, that's sort of the short term. And I think there are also some conversations, and I think it's useful to think about what does all of this mean around for quality reporting, in more as we move forward. And I think there are a lot of folks who are in the quality community who are thinking about what does this mean for quality reporting, be it for physicians as well as other hospitals and other systems within Medicare and private payers. I mean, MIPS was always supposed to be sort of this transitional program. CMS wants to get people, clinicians, into APMs. There was, even before the pandemic, MIPS was seen as burdensome by clinicians. It's burdensome for the agency to maintain. And now that the agency has sort of hit a pause button on quality reporting in some ways, I think there are some discussions going around about, kind of what may eventually emerge from what comes out of this time period. I think what a lot of people and a lot of the quality folks are saying is that for years there has been some criticism of the quality reporting programs. They've been around for a while, and it's really hard to measure what impact they have had on the healthcare system. COVID has really revealed a lot of the disparities and inequities in the system. And I think there's been this ongoing frustration around measures. CMS has, said that they've spent over $1 billion developing quality measures. I'm sure AOA has spent a lot of money and has staff who are involved in the development, whose job it is to help develop measures. And you have committees around developing measures where you're volunteering your time to do that. But the measures really haven't gotten to the point where folks would like to see them. Most of the measures still in Medicare quality programs continue to be process and not outcome. And I think, finally, there is this real acknowledgement that unlike maybe what's going on in the payment model world, where Mara will talk about more, that their quality reporting is a real burden for physicians. And I think the other kind of variable to think about that may kind of move the ball a little here is that there's a couple of things. I think there's one is that Congress has allocated billions of dollars to help providers kind of get out from under the water due to the pandemic. And providers are still in significant financial stress. And there's uncertainty about how 2020 will play out. So with all of that going on, I think CMS will want to be cautious, or stakeholders will ask them to be cautious in dinging providers who are, under this continued financial stress, and dinging them for not reporting quality measures, or if their costs have gone up due to the steps that they have to take in order to care for patients during the pandemic. I think the other thing that, when we're thinking about where is quality reporting going, I would say the other variable is telehealth. There has been, I'm sure many of you have started providing telehealth services much more than you did previously to this pandemic, as have providers across the country. And so there's been this uptick in telehealth. And depending on the telehealth flexibilities, if they will remain, the uptick may continue, and these may become a permanent part of the healthcare system. There's been talk about, do we now that we have this modality, that more and more services, the way services are being provided, do we need measures to account for how these services are being provided, to measure their quality? HEDIS measures were recently adjusted to account for telehealth. And I think in the last couple of years, NQF has been working on a framework for evaluating telehealth services. And I think if the utilization of telehealth services within physician world continue, that could be another factor. And I think all of these factors are things to think about as quality reporting evolves and changes in the near future. So finally here, on this last slide I have is this section. We have the National Quality Roadmap that was released by the administration on May 18th. I know it's a little difficult maybe to read on your computer screen, but what I'd like to point out is, I think what it does is it illustrates sort of the vision of the administration for where they want quality to go. And I think on the slide here, I've identified what key implications are for physicians. I mean, I think the agency, in terms of measures, they're looking to streamline it, and so more sort of overlap between hospital and physician measures, and so that potentially could reduce the number of measures for physicians. I think the data component of this quality roadmap means that there's a continued focus on public reporting and more robust public data on how clinicians perform. And finally, I think that this idea of governance and greater governance in the quality space, the administration is looking for greater coordination and alignment of programs within government and across payers. That being said, and dedicating a full slide to this, I would say there's 2 points to make, and that to put this in some context is to note that this was largely created prior to the pandemic, and that a change in administration in November could also mean a change in how quality goals are articulated, priorities made, and how they're implemented. So with that, I would like to leave you with sort of 4 key takeaways as you're thinking about quality reporting for your practice now and in the near future. So I think for 2021, payment adjustments, some accommodations have been made, and hopefully the risk of negative payment adjustments for physicians and physician groups has been eliminated. as we're entering, so that I think is a good thing. But as we're entering the third quarter of 2020 and you continue to face challenges as the pandemic continues at some level across the country, I think you will continue to face challenges, and it's likely that CMS will need to make further accommodations to address how performance is measured or what your burden will be to participate in these programs. And I think for this to happen, I think groups like AOA and other stakeholders really need to keep the agency's feet to the fire, and they need to hear from you about the challenges you face. And I know you have a great staff here, and they are doing that, and they will do that when the proposed rules come out, and in other opportunities like that. I also think that this combination of this overall dissatisfaction with quality reporting, with the disparities that have come out, with the pandemic, as CMS has kind of hit pause, and how services are being changed a little in terms of a greater utilization of telehealth. I think all of that could also create some revisions in how quality measure priorities are articulated and implemented by the agency. So thank you for your time, and I'm going to now hand it over to Mara.
Thanks, Shella. Appreciate it. Hi, everybody. Good evening. Nice to be with you all. As Shella mentioned, I'm Mara McDermott. I'm a vice president with McDermott Plus Consulting. And my background, I started my career as an attorney at a large law firm in Washington, D.C., where I did a mix of Medicare regulatory work in the payment model space and drug space and all across the healthcare industry and lobbying on Capitol Hill. I then spent several years with a professional association for risk-bearing physician organizations. When I started with that group, it was called CAPG, the California Association of Physician Groups. And today it is America's Physician Groups, because the membership has expanded well beyond the state of California. I joined McDermott Plus just over 2 years ago, and my practice focuses, as will be very clear from this talk, mostly on value-based payment models and other sort of Medicare payment features. And I do a lot of work still in the physician practice space. So it's really nice to be with you all. Just a reminder that if you guys have questions either for me or Shella and you want to pop them into the Q&A box, we are happy to answer those at the end of our time with you, or if we happen to see it pop up while we're talking, I'll speak to it then as well. Shella, we can go ahead to the first slide. I wanted to start with just sort of a level set, a reminder of kind of where we've been. I know that coronavirus has taken the attention away from many of these topics, rightfully so, for many months. So just a little bit of a refresh in terms of where we were. When Secretary Azar came on the scene with the Trump administration, the new Secretary of Health and Human Services, he articulated 4 priorities for the Department of Health and Human Services. One, of course, was the opioid crisis and health insurance reform, or otherwise, sort of what was going to be the Trump administration's answer to the Affordable Care Act and the changes that needed to be made to coverage in their view. Drug pricing, which was a pretty hot topic both with the administration and on Capitol Hill for much of 2018 and 19, and now has largely taken a back seat in terms of priorities, both for the agency and for Congress, as we all wait for prescription drug manufacturers to rescue us with a vaccine for COVID-19. And then finally, of course, value-based care. And within that bucket of value-based care, there was a significant focus on new models, and in particular, new models that were going to change the direction away from fee-for-service and build on what I would say, although they may not say this, the successes of delivery model reform that the Obama administration had begun. So Shella, we can go ahead to the next slide. One thing that I would say, picking up on sort of Shella's comment about the 2020 presidential election, what we've seen over the past many years, I would say going back all the way to 2014 pre-MACRA, but probably even before that, is a bipartisan commitment to changing the way that physicians and health systems and others paid by traditional Medicare are paid. And while there is nuance and difference in terms of where the focus is and the tone and tenor of that change, I think what we've seen a pretty consistent direction in terms of where leaders across both parties have wanted to go in the movement away from fee-for-service and towards something else, right? The nuance and difference that we see from this administration is really an emphasis on shifting financial risk from the federal government onto local care delivery systems, which includes physicians, health plans, health systems, and others. And this administration has talked pretty broadly about even including vendors in that and having everyone sort of bear risk except for the federal government in the traditional Medicare program. That is, to me, a movement and a shift from where the Obama administration had been, which was largely to get participation in the models before forcing providers, physicians, health systems to take that downside risk, the risk of financial penalties. The other nuance I think we've seen with this administration is the movement from fee-for-service specifically to capitation. So whereas in a previous administration, we saw a lot of emphasis on moving to two-sided risk over a longer period of time and getting into models where there were incentives to save money for the federal government, this administration and the leaders at the CMS Innovation Center have been pretty bullish on the concept of prepayment or capitation, however you want to label that, and they certainly use that term in different ways, but really being pretty clear about the idea of changing the payment mechanism away from fee-for-service in addition to achieving savings. The third thing I would say where I see difference is the idea of beneficiary engagement. So what we saw previously with the Obama administration was this idea that the ACO or medical home could kind of happen in the background for the patient, that the patient would not necessarily even know that that was going on and that that was a policy choice that was being made intentionally, and that this was, these were participation options for physicians, but the beneficiary would benefit, of course, from the care experience being more coordinated, but wouldn't be electing participation in the model. We've seen a shift away from that, I think, to be determined whether or not that's going to be successful, but starting to encourage beneficiaries to elect participation in these types of models. So me Medicare beneficiary, I am going to choose to participate in ACOX or with medical home Y, the same way I would choose to participate in health plan. And then a focus on reducing provider burden. And what we've seen with this administration, and I think is actually pretty consistent across many years, is the idea that if you're going to play ball, if a physician is going to participate in one of these models, the part of the equation in terms of the benefit to a physician for doing that will be a reduction in their Medicare paperwork burden, reduction in quality measure reporting, other sort of types of ways that the administration can reduce burden on physicians and physician practices. Shella, we can go ahead to the next slide. So when I was preparing for this presentation, I was looking for some evidence to support my case about fee-for-service Medicare, and came across, of course, the AOA study, which perfectly underscored my points. So I included it here, but I won't pretend to know more about it than the AOA staff on the phone, who probably have lived and breathed it. But the main point that I wanted to make here is that I think for many physicians across the country, the effect of COVID has been to really underscore the vulnerabilities of the fee-for-service payment system. So as volume has dried up, so has revenue, and physician practices are really hurting as a result, which I don't need to tell you, you all know that. And this is something that we see across all of the types of physician practices that we work with, or regardless of focus or specialty or sort of primary care or otherwise, just a very dramatic decline in revenue and a need for some relief from the federal government. So Shella, we can go to the next slide. In terms of sources of relief, and we won't belabor this, it's sort of outside the scope of this and this talk, and I'm sure that you all have had many separate presentations on these, but there have been some short-term relief offerings for physician practices. The feeling that we've, or sort of I shouldn't say the feeling, the feedback that we've gotten from the physician practices that we work with and the specialty societies that we work with is that the amount of relief offered has just been woefully insufficient to keep up with the shortfalls that we talked about on the previous slide. So while there are options that include the Provider Relief Fund, which is a grant program that was funded with about $175 billion from 2 previous stimulus bills, in my view, a relatively small share of that has gone to physicians and a relatively large share of that has gone to hospitals in a way that, I think is a little bit unfortunate, but that is one available option. Small business loans, the advanced payment program, which is not a grant program, but allows physicians to tap into prepayment of their otherwise expected Medicare revenue, and telehealth visits, which Shella talked about. As we start to think about longer term solutions and longer term relief options for physician practices, certainly telehealth is one area of possibility, right? We could see Congress and the administration working, and I think it would take efforts from both of those entities to make permanent some of the changes in the telehealth space. But the other one where we see some opportunity, depending on how it's implemented, is in this transition away from fee-for-service. So can you create relief in relatively short order and bolster physician practices for the future by moving them into these value-based care payment models where some amount of revenue is prepaid based on the patients that you see, the patients that belong to your practice or a part of your panel, and that would cut down on this reliance on volume and provide additional resources for patients who are for physician practices as they transition away from fee-for-service, but in the case of future pandemics or other sort of disruptions to that patient flow. As is always the case in my COVID life, my dog and my 6-year-old have now joined this presentation, so hopefully they will be quiet. So let's move ahead to the next slide, please. So one mechanism that the administration was exploring prior to the COVID-19 pandemic was a primary cares initiative, and we're going to continue to see this initiative move forward coming out of COVID. The CMS administration, the CMS Innovation Center has announced that they are going to go ahead and continue with these models. We'll just very briefly talk about sort of an overview of primary cares initiative and then dig in a little bit deeper on both. As back in April, over a year ago, so not this past April, but the one before that, the Department of Health and Human Services and CMS and the CMS Innovation Center, which at the time was led by Adam Bowler, announced the Primary Cares Initiative. And that initiative consisted of really sort of 2 payment models, but 5 different components of those payment models. So one was Primary Care First, which is will now be the most advanced primary care medical home option. A Primary Care First seriously ill population option, which is a variant on Primary Care First, as the name suggests, aimed at the seriously ill population. And then 3 different tracks of direct contracting, which is an advanced ACO type of model, and as we'll get into a little bit more detail, would require providers to take some amount of capitated payment. So let's move ahead to the next slide. The one thing that I wanted to just emphasize for you all in terms of themes that we're seeing from this administration is this focus on prepayment and the movement away from fee-for-service. So we see it with Primary Care First, which we're going to talk about. We definitely see it with direct contracting. There's another set of models I just wanted to briefly mention that we won't get into on called Kidney Care Choices, which creates the same type of payment mechanism as direct contracting. If somebody's asking if we can go back a slide, which we definitely can do, but for the ESRD population. So I just wanted to sort of throw that in to let you all know that there is a set of models, all of which are focused on moving away from this fee-for-service payment model towards prepayment. So Shella, if we can go back one slide to slide 21. So just to sort of recap on this slide, CMS and HHS together announced what is called the Primary Cares Initiative. It was the announcement of a set of payment models that are focused on primary care services, but in different ways, right? So we have two sets of models called Primary Care First, which is the advanced version of the Comprehensive Primary Care Initiatives or CPC Plus type of model. It is an advanced medical home for the Medicare population and can involve other payers. The Primary Care First option is sort of a standard medical home option with advanced services and offerings for your Medicare primary care patients. The seriously ill population variant on Primary Care First will allow those practices to access additional resources to care for patients with multiple chronic conditions and who meet certain criteria. The second component of the Primary Cares Initiative is the direct contracting set of models. And within direct contracting, which is really an evolution of ACOs, it's a advanced ACO type of model, there are three different tracks. One of those is a professional risk track, where a direct contracting entity, so that ACO entity, would be capitated for certain primary care services and continue to be paid fee for service for other services, specialty services, and those that are not on the primary care list. There's a direct contracting global risk payment option where you're capitated for a broader scope of services, right? You define what goes into that, but it would be beyond just primary care. So, sort of the patient or for the physician services that are within your network in that direct contracting entity. And then a direct contracting geographic model, which has been very loosely defined to consist of a direct contracting entity that would provide capitated care for a specific geographic region. So you would think about an ACO for the state of Ohio, for example. Now, they've not said the state of Ohio. They've not picked any regions or areas for that geographic model. They haven't put out any letters of intent or applications. So don't get nervous about that, but just wanted to sort of put that out. We have another question, where does telehealth fit into this slide? So telehealth has been a strong part of all of these models. And I think one of the challenges for CMMI is to figure out how the changes to telehealth that have been brought about by COVID are going to interact with these types of delivery models. And there are a few different ways that that plays out. So one of them is around attribution. How do you figure out which patients belong to the ACO or direct contracting entity or primary care first practice? Is a telehealth visit sufficient to create that nexus for alignment, or is something more going to be required? Would you weight those visits? How does that fit in? And then I think there are other questions around the types of flexibilities that a advanced alternative payment model, a direct contracting participant, a primary care first participant might have that a sort of fee for service, a physician just participating in fee for service wouldn't have. So one example of that might be, would CMMI allow a physician participating in a direct contracting model to provide telehealth services in a patient's home, with a patient in their home, versus sort of maybe not allowing that broad of an expansion of the originating site rules for a traditional Medicare patient? So I want to be mindful of the time and make sure that we get to our questions. Let's go ahead, Shella, and skip. We can skip that one and go ahead to, slide 23 is great. So just to spend a couple more minutes on primary care first, and we have more detail on this in the slides, which we'll share. Like I said before, primary care first represents an evolution of the advanced primary care model that CMMI has been working on for many years over the course of multiple iterations. It's an advanced primary care medical home that will be offered in 26 regions in 2021. This model is a multi-payer model, so it includes both traditional Medicare, but also CMS is also encouraging Medicare Advantage plans, Medicaid managed care plans, and state Medicaid agencies to participate in the model, so to align their payments and the way that they pay providers to the way that primary care first is structured. Applications for this model were due back in January of 2020 for the 2021 participation year. We expect that there will be subsequent applications, and then this model begins in 2021 in January for the sort of routine primary care medical home piece, and in April for that seriously ill component. Shella, we can skip ahead to slide 25. Thank you. So in terms of how this works, one of the things that is, I think, thematically fits in with the COVID response is that primary care first offers a combination of population-based payments, a flat primary care visit fee, and a performance-based adjustment. So you're being measured across different quality measures and efficiency measures, and you're receiving a flat visit fee. So there is still that fee-for-service component, as well as a sort of per patient payment. So really starting to see that blend of fee-for-service payments with other types of upfront payment to create cash flow with a goal of moving away from fee-for-service. There is an opportunity in this model, at least on paper, to increase practice revenue by up to 50%. My word of warning on that is that we often, and Shella knows this well from her experience with MIPS, and I'm sure all of you do too, we often see indications of high potential revenue gains on paper, and what you really need to do when these models come out is run the math for your specific practice to determine whether that is a reality on the ground for you. And we are still waiting on a lot of details, additional details in terms of how the primary care first payments are going to work, and the calculation, and all of those different components, the quality adjustment, all of the other pieces that I've talked about. So much more work to be done there, but some promise of moving us away from fee-for-service and towards other types of payments. Let's, Shella, jump ahead to slide 27, and I won't spend a ton of time on this one, and then we can move on from there. So at the same time that CMMI is advancing the primary care first set of models, they are also advancing the direct contracting models. And here we see a similar type of theme, right? This evolution away from a reliance on fee-for-service towards prepayment options. In direct contracting, you start to see a requirement that providers take capitated payments if they're going to participate, and that will mean that that direct contracting entity, which is known to all of us right now as an ACO, will take that prepayment and then determine how physicians are paid downstream from there for the services that are capitated within that direct contracting arrangement. Direct contracting features higher levels of financial risk and potential reward. So there is a greater expectation that direct contracting entities achieve savings for the Medicare Trust Fund. They also have the potential to keep more of those savings than they have in the past. Direct contracting uses what the agency is calling enhanced voluntary alignment. So they're going to allow, CMS is going to allow direct contracting entities to actively recruit patients into the direct contracting model. Patients will sort of sign up, very similar to what is done traditionally with health plans, to participate with a direct contracting entity. It remains to be seen how those rules play out and how much flexibility direct contracting entities are going to have in terms of signing up patients or, sort of going out and recruiting in their local communities. There are some additional tools that direct contracting entities are going to be able to use in terms of offering supplemental type of benefits to beneficiaries who elect to participate in the direct contracting model. And then the final thing that I'll mention that's just, sort of consistent with the way that ACOs have operated in the past are additional waivers of somewhat burdensome Medicare rules. So we really see those themes from the administration around allowing direct contracting entities and those organizations that are taking these higher levels of financial risk to have additional flexibility and burden reduction in terms of their traditional Medicare payments. So let's go ahead and move, Shella, ahead. Let's just pop over to slide 31, please. So in terms of what the administration has done with regard to these models and other models in response to COVID-19, this CMS Innovation Center has really, I think, and CMS in general, have made a lot of efforts to be good partners for organizations that have already taken or plan to take downside risk. So to the extent that you're part of an accountable care organization now or looking to be part of a direct contracting entity in the future, the administration has taken steps through the rules that Shella mentioned to protect those organizational participants from downside losses. And that could take the form of a cap on losses or just ensuring that there are no losses, that the amount of losses that you face are tied to the public health emergency period. So if the emergency period lasts for a year, you would basically not have any losses at all. And I think that what we've seen is the administration really come to the table as a partner in a lot of these cases and to work with ACOs to try to find solutions. That being said, as Shella said about MIPS, it still feels to me like there needs to be one more turn of the regulatory crank to ensure that model participants, both current and future, have what they need to be successful in downside risk models and to be sure that they'll be protected in the event of massive disruptions like COVID-19. What we are seeing is sort of a split screen in terms of the move to these types of alternative payment models with the clients that we work with. On one hand, I think some of the larger systems are maybe have a higher level of nervousness about moving to these types of models in terms of the exposure and the massive financial disruption that they've seen. On the other side of the screen, I would say we have a number of physician practices who are maybe considering a move to primary care first or considering a move to direct contracting, and COVID-19 and the experience there with fee-for-service revenues has really ignited more of a spark around getting into those types of models, again, to address that cash flow problem. I think that one sort of remaining issue for conversation is what additional steps can Congress and the administration take to incentivize the move to value-based care. Certainly there are financial incentives that could be better put in place or sort of adjusted or enhanced. I think back to the MACRA 5% bonus, just making sure that those organizations that are taking this leap to value are being encouraged to do so and receiving the incentives if they elect that route. And other things that we talked about, like with telehealth or other types of waivers that the administration can do to continue to make value-based care models attractive going forward. So with that, I see that we have about 5 minutes remaining, and I think that what I'll do is turn over to the question and answer box or the question box and see what we have there. The first question, Shella, I think may be for you. If either of us is going to know, it's going to be you. How much will a doctor get per patient starting in January 2021 for a telehealth visit? Will this amount be the same for an APN/PA?
Right. That's a good question. I think at this point we don't know. So what's happened during the public health emergency is that one of the flexibilities that they they had around telehealth was they expanded the number of visits, but I think in terms of the payment issue, they said that if you, historically, when you do a telehealth, like E&M visit, um, CMS would pay the facility fees. So that was the lower amount as if you were performing the E&M visit in the hospital, and you wouldn't get the practice expense, sort of the supplies and equipment and all of the overhead as if you were performing it in the office. And so during the public health emergency, CMS has said if you are an office-based physician, or practitioner, you will receive, if you're doing the E&M visit by telehealth, you will get that office-based rate, which is higher. And in the higher level E&M codes, level 4, I believe, and 5, it's about a 30% difference. It's 30% higher than in the office versus the facility. So one of the variables here is we don't know if the public health emergency will be extended to January 1. And so right now, I believe it's supposed to expire in near the end of July. It may be renewed, and it gets renewed for 90 days. The other sort of variable is if there are things that the agency can do via regulatory. And so I think one of the things that the agency has indicated in some public comments recently is that they will be using the upcoming 2021 physician fee schedule proposed rule that's expected on or around July 1. They'll be using that as a vehicle to discuss some telehealth policies that they may want to make permanent. So I think that is a big question that a lot of folks have, is if they will maintain that idea that office-based physicians can continue getting that office-based rate, permanently when they do the telehealth visits. But I think at this point, we don't know if that will happen come January 21.
Thanks, Shella. So we don't have any other questions. I will just conclude by picking up on something that you said about the public health emergency. I think one thing that we've been watching really closely, both for MIPS purposes and telehealth and all of the waivers that have flowed from COVID-19, is what happens with those various emergency declarations, both at the national, sort of the presidential level and the HHS secretary level, and how that, ending either of those prematurely could be very disruptive in terms of the availability of those waivers. So to the extent that you all are using those telehealth and other waivers in your practices, I think that's something worth keeping an eye on.
And Mara, you'd say that there's generally been a lot of advocacy around the telehealth, both at the congressional level as well as indication from CMS and with stakeholders that there is a desire to maintain at least some of those telehealth flexibilities. Do you think that's a fair?
Yeah, I think that's totally fair. I think there's been a lot of energy from the CMS administrator and other leaders in the administration, as well as a large group of senators and numerous House members who are very invested in keeping those telehealth flexibilities. I think there remains an issue of timing, right? If the either national health emergency declaration or the public health emergency declaration at the HHS level were to be terminated prematurely, how does that align with the rulemaking cycle and congressional legislation? And so that's just, I think, something to keep an eye on, but I totally agree that there's a lot of momentum behind those telehealth changes.
And I think one interesting comment that the administrator, Seema Verma, had made, maybe it's been about a month, was that she doesn't see these as being an on and off switch, and they kind of want like a slow sort of descent into this. So I think that to me was an indication that they see this as maybe more of a gradual change.
Yep, I agree. So we'll all be watching that physician fee schedule proposed rule very closely. Okay, I think that we are at the end of our time. So I don't know if the AOA staff want to close us out or if we
Um,
close ourselves out.
we actually just had 2 additional questions come in.
Okay, sure.
I don't, frequently the administration and Congress try things first in the VA and the DOD. Do you see any indications of this happening?
Yeah, Shelley, feel free to chime in on this one too, but I think that because everything with the emergency period happened so quickly, we haven't seen that as much in this case. It's been more of a rapid response. And now, because so many patients are really enjoying the convenience, safety, and flexibility of telehealth visits, they're not going to need to go in that sort of phased approach, at least with on the telehealth side. So I don't think I see that as much in this case, although I tend to agree with the questioner.
Yeah, I think, I wonder, I know that in the DOD and the military in general, their experience and their use of telehealth is so much more significant, and historically it has been. And so one of the things I think will be interesting to see is if they decide to maintain the expansions in telehealth at some level, will Medicare look at the VA and DOD for models of how it should be done.
Okay. All right, and then the last question that came in is, how do we keep updated on these? I feel like we are left in the middle.
I also feel like I am left in the middle. We have a ton of resources on our website, McDermott Plus, the McDermott Plus website, which I think is included in these materials. We are actively, sort of trying to predict what's going to happen with the election and what's going to happen with the physician fee schedule. We'd be happy to come back if we were invited to give you another update later this summer. Or in the fall, but in the meantime, I think there are a lot of resources out there to stay up to date, and especially we'll have lots of summary papers as legislation is passed and as rules are introduced and then finalized.
Mm-hmm.
And one of the things I would note is our emails are on this slide set. We have some weekly emails that go out. One's focused on payment innovation. Another one is sort of a what has happened this week at both congressionally and in the administration and elsewhere. So if you send us your contact information, we'd be happy to sign you up for those listservs. And it's kind of a way to get weekly information from us.
Okay. Now everybody's waking up. Okay, VA is allowed to cross state lines with any medical license to do telehealth. Will this happen nationally, in your opinion?
So I don't think we've seen that yet, and I don't know that this administration would be particularly inclined to do that that type of change, to go, sort of override the state's prerogative on that. So I personally don't see that happening nationally, but I don't know, Shella, what are your thoughts?
No, I agree. I think that's probably true. But one thing I wonder is, there was a call, it was a sort of a public call that the White House did, and I think you were on this as well, Mara, maybe a week or two ago, and where they were encouraging states to expand things at a state level that they may not be able to do nationally. And so it'll be interesting to see if the administration is encouraging states. And I think some of these issues that they were looking at there were 2 issues: telehealth as well as non-physicians practicing at the top of their license. And those were 2 areas where I think Medicare staff were talking to states about what they could do at a state level to move on in that area.
Okay, and the last question, are you involved with the current administration?
So no, neither of us work for the administration to the extent that we lobby the administration. We do regularly meet with officials from CMS and HHS and the Innovation Center and share our clients' perspectives with those officials, but we are not, sort of employed by or contracted with the administration directly.
Okay, very good. Well, thank you again for a wonderful presentation. I just want to go over a few of the resources that are available. The first one being the physician support line. This is a free physician support line that actually was put together by a DO that felt that there was this need for this, that the physicians out there on the front lines are feeling a little overwhelmed, stressed, whatever. If that happens to be someone listening, or you know someone that could benefit from this, please share this information with them. And then next, I wanted to talk about the osteopathic.org, our COVID-19 page. We update that regularly. Our DC staff provides updates of what's going on, what they hear in DC, and that gets updated weekly. Anything that happens during the week that needs to urgently go out also makes its way to this page. So this is a page that you could check back regularly for. And then going further, we have some of our on-demand webinars. We've had something like 14 or 15 webinars through COVID, and these are available both for CME and for non-CME. They are free to AOA members and free to anyone if they don't want CME. This is just a sampling of them. Again, they're on the COVID website or as well as the AOA online learning webpage. And then some of our upcoming webinars that we have are Advanced Wellbeing During and After a Pandemic. That's scheduled for July 28th. We have a reopening of your medical practice. That is actually scheduled for July 22nd. That was just handled today. And then we have some others that we don't have dates for yet, but that they are in the works, and those most likely will be in August sometime, on protecting your patients and your staff to stress-induced violence. Unfortunately, we are living in crazy times, and this is an important one to pay attention to, as well as the cybersecurity. There are people out there not doing nice things that we need to make sure that you're aware of. Again, those will all be advertised to you and available on the AOA online learning platform. And then, as always, the physician services team is available for any questions that you may have. Those of you taking this for CME, following the presentation, you can go back to the AOA online learning website, go into the actual course, and within there you'll see the post-evaluation. Once you take that, you'll be able to either download or print out your certificate for your records, and then the AOA will be submitting those to the CME department. And then the last slide is of the physician services department. That is our direct line, as well as our email address. Any questions that you may have, feel free to send them in there. We will do our best to get an answer for you. If we can't answer them ourselves, we will reach out to one of our speakers that has presented. So in this case, if you wanted to reach out to Mara or to Shyla, we would have that information. We'd be able to share that, reach out to them if we couldn't answer the question ourselves. So thank you all for joining us. Thank you, Shyla and Mara. Great presentation. We do appreciate it. And you're certainly welcome back anytime to provide and share your expertise with us. We truly do appreciate it. And that concludes tonight's webinar. Thank you all for joining.